Mick, it's a great privilege to be here and to be with so many friends at last. I've missed you all. I think we've all missed each other. So I've got this great pleasure of being able to give a keynote, talking about the opportunities and challenges for public health preparedness and response, and the Sendai framework for disaster risk reduction, which I think many of you know is something that I've really cared about for years. But I've also been really concerned to look at complexity and how we can handle these things. And trying to bring all this together is something that I'm going to try and show with some fun, well, a lot of information, but hopefully things that you will find useful. None of us will forget COVID. I know. It's slightly written on our hearts and on our work in disaster medicine and in all the multidisciplinary agencies that have been involved in trying to understand these impacts. But to me, being able to understand the scale of it and the size of it is something that I think has been really, really important. This is the World Health Organization's dashboard for May the 3rd. And there's not much that hasn't reported somewhere that there have been cases of COVID. And we know that there have been probably over 700 million cases that were confirmed, very nearly 7,000 deaths confirmed, but also billions of vaccines that have been given. How complete these figures are is something that will appear probably in the future. But what I did love so much about the work we did was that in March 2022, just after the fake was announced, but before the full lockdowns occurred around the world, they brought together in the World Health Organization a coordinated global research roadmap agenda, which was very much directed at trying to provide the very best evidence we could of the processes that are going to matter the most, really trying to make it as useful, usable, and used as possible. They outlined what was needed from this wonderful negotiation, and then updated it a year later, where by this time we could see where in the world each of these research projects had happened, who was the property owner for each project, how much money had gone to the projects, and how it was progressing. An incredible resource that was developed by GLOPIDAR and the UK Collaborative on Development Research. Something that I've never seen before, that we actually tried to prevent duplication of work, but trying to bring together all the actions that were needed. Is this something we should be doing for disaster medicine? Is this something that we will do for disaster risk reduction and all our research programs? I know that Riamar, who's in the audience, and I have talked about this before. But the best thing was last Friday, the UN News reported that WHO declares the end to COVID-19 as it no longer constitutes a public health emergency of international concern. Something that we are aware of, but of course the problem has not gone away. And inevitably, when you've had such a global problem, there has been all sorts of independent reviews. And this one is one of my favorites from the independent panel on pandemic preparedness. And I highlight here some of the COVID-19 consequences in their snapshot that they shared. By the 28th of April 2021, we knew that there had been over 140 million cases, with 3 million deaths in 223 countries. But Paul, Varric, and I have been talking about the fact that the numbers of healthcare workers who died is certainly not really fully represented there, and it's probably much nearer 250,000, isn't it, Paul? And we know that healthcare workers are such a wonderful and finite resource, and we need more of them, but we need to make us all safe. We also know that 80 to 90% of the world's school children probably didn't go to school for at least part of 2020. And what frightens me is how many actually went back to school. And have they learnt enough? And what have we done to them? And we know gender-based violence increased enormously, and that we've pushed many more back into extreme poverty with this pandemic. Things that really frighten all of us, I suspect. But one of the things they did say that was that multi-sectoral coordination of preparedness has been lacking. Something that we're all addressing now to see how we can look to the future. And in this, they put in a statement which to me resonated closely. While the Sendai Framework for Disaster Risk Reduction includes pandemic risks in its purview, disaster risk reduction capacity building has largely been separated from the health sector for pandemic preparedness efforts. So we were left to do it alone, not to do it with everybody else. So this is why we need the Sendai Framework in disaster medicine. So I just wanted to share with you some thoughts about the Sendai Framework, something that I think is really important. It was such a privilege to be so closely involved in the major group on science and technology and to be the vice chair of the Science and Technology Advisory Group for UNISDR to try and deliver this framework. We saw how long it had taken to develop the idea that we could have the Yokohama Agreement, the Hyogo Framework, and the Sendai. So Japan, sadly, are celebrated because they're all named after Japanese disasters. But the disasters across the world don't only happen in Japan. What you've always done is to stand up and help us to think what we should do in the future. And the Sendai Framework was the first one agreed in March 2015. And then we got to the Sustainable Development Goals, which came in September 2015. Yes, they certainly included a health element, as Nigel Crisp talked about on Tuesday. But also, we got the Paris Agreement, agreed in December 2015, and finally we had these visions that should work together. So it's thinking about how we can give this world vision after a pandemic that we need to think about now, in my view. The Sendai Framework, you may remember, is this very thin little document where each paragraph, each single word inside each paragraph had to be agreed. And then finally the gavel would come down and that paragraph would be embedded. Amazing. Only 50 paragraphs, quite a lot of sub-paragraphs, but so much thinking and so much science and health in it. So what did they really call for? They called for a global outcome. They called for 13 guiding principles, which did include human rights and science. It did also include 4 priorities for action, but finally we got to these 7 global targets with 38 indicators underneath them of reducing mortality, affected people, economic loss, and damaged infrastructure, particularly health and education. But we also had to increase our awareness of what the hazards were. What are we to prepare for? How should we do this? And that we needed to have much better international cooperation and much more effective early warning systems and early action. Huge targets, hugely important. But what was a delight was that health is embedded inside the Sendai Framework. This may be perhaps the most useful framework, the most useful paragraph inside the framework, which talks about the resilience of health systems, developing the capacity of health workers, promoting and enhancing the training capacities in the field of disaster medicine, and in the implementation of the international health regulations of the World Health Organization. In fact, the international health regulations are mentioned 3 times, but we've done a lot of thinking about that since, because is this enough? So working with Jonathan Abrams and many, including Rioma, there was a lot of thinking about this, and taking together all sorts of different resources from around WHO and the regional offices of the World Health Organization to bring together to agree that what we needed was the WHO Health Emergency and Disaster Risk Management Framework. What it did was to take the international health regulations and say, these are good. These are mandatory for ministries of health, but not for the whole of government, whereas we need something for the whole of government and the whole of society. Take those international health regulations, take the Sendai Framework, map them, and show that the Health Emergency and Disaster Risk Management Framework brings in that whole of society, whole of government approach. We also know that this wonderful framework of which we are so fond and seeing its travelling and engagement much more now, including in cities and local areas, that we need to align global health security, something that COVID-19 has told us we must do, align disaster risk reduction, align humanitarian reform, align climate change and sustainable development agendas as outlined in the 2015 UN landmark agreements. What we know is this framework bridges health and multisectoral communities. That we touch all those different people, from the people who provide the power for our hospitals, the transport to and from our hospitals, the laundry services, all of them, even the water supplies, the food chains, all of them are bridged if we use this framework properly. But what it also does, it comes from what we've already done. It's pulling together under one umbrella all these different pieces of work we needed to share. So it's derived from health systems, risk management, emergency and disaster management, epidemic preparedness and response, but also something that's going to be increasingly important for the future, climate change adaptation. Now, there's a wonderful website on WHO where so much of implementing health emergency and disaster risk management sits. I'm sure you've all seen this website. Do look for it, do go to it. It's beautifully updated, and it's a real joy to see. And one of the things it does contain, but which I'd now divert to WHO Kobe for, where Riamar comes from, so thank you, Sarah, Mackie, all of you, is the work that we've been doing for the WHO Research Network for Health Emergency and Disaster Risk Management. Riamar shared this on Tuesday. Thank you, Riamar. And we're going to try and invite you all, if you're interested, in joining our network. We feel this network provides you, your students, and other groups an opportunity to start thinking about how we can work together to make sure we deliver things that are going to be very important. We know there are certain research areas that we have to work on. And we know, for instance, some of that was delivered by a wonderful presentation by a colleague looking at some of the issues of capacity for healthcare professionals and the impact of COVID-19. Some shocking results showing how much our healthcare community has suffered in the middle of COVID. But we also know we need a knowledge hub to share that information, and that's something that's emerging. It's not quite there yet, Riamar, I know, but this is. We have a new WHO guidance on research methods for health and disaster risk management. The first version, having thought about this in 2019, was published in October 2021. We did it through COVID. I cannot thank so many of the authors who are in the room, some of you, to say thank you to you for all the help you have given us in trying to do this. But we know that we're not static, we need to do more. So if we look at this lovely new textbook or resource which sits on the table over there, and for those of you who have not touched it or felt it or signed it, must come and do so, please, later. It talks about why we have this guidance. It talks about identifying, understanding the problem. It talks about determining the scope of your study, so it's very much directed at how you, as researchers, your students and others will think. It talks about study design, something we really spent a lot of time thinking about on quantitative and qualitative data. It gives you special topics to demonstrate research processes and benefits, and we've added a supplement on addressing emergency research needs, particularly on COVID-19. And I had the fun time of trying to include in that the infodemic summary that was one of the things that really worried us. And that's been talked about here too. And also how to become a researcher. But how has this been done? So Riamar, thank you for your leadership. I really mean it. It's been a privilege to work with you, Mike Clark from Queen's University Belfast, I'm very sorry he's not here, Emily Chan, but also with Tracy from Canada, and indeed Jonathan, who's now at Monash. But the authors and peer reviewers came from 164 in different 30 countries. But every single regional office of the World Health Organization is represented. I'm so proud of them all. But the best thing is, Riamar, we got the message only yesterday morning that for each chapter, there is a webinar, there are videos, there are podcasts, so you can use this to help inspire this work. And we know that we will identify gaps and we need your help. So by sharing this with you, we want you to get much engaged. But we know that the health system is not necessarily very good at sharing what it knows. So how do we get health to engage with the Sendai Framework Monitor for reporting on mortality, on morbidity, on affected populations, on impacts on healthcare and other facilities? This went live in 2018. Well, that's the first time we had our first report. And one of the things we found was when I went to that report, that people found it really difficult to understand what the hazards were that caused the disasters. So paragraph 24J of the Sendai Framework of strengthening technical and scientific capacity to assess disaster risks, vulnerabilities, and exposure to all hazards became increasingly important. So what did we do then? Well, I was asked by the United Nations Office for Disaster Risk Reduction and the International Science Council to be the chair of a technical working group. A huge privilege. We published our first report, the Hazard Definition and Classification Review, please note, in July 2020. Lydia Maynor, for our Australian colleagues, she helped us so much. And then we published the Hazard Information Profiles, again in October 2021, once it had been copy-edited because I had spelling problems, I discovered. But who was part of the whole system? This was a network of the most incredible UN agencies and organizations. Of course, the World Meteorological Organization was there, the World Health Organization, FAO, but there were over 40 that we worked with and talked with. All the International Science Council partners, including integrated research on disaster risk, all the way through to our business partners with the Insurance Development Forum and our communities, working very closely with the International Federation of the Red Cross, Red Crescent. Yes, we had that technical working group, but what we also had was this incredible network of others who volunteered and got so engaged and who reached out to us and reached back to us. So it was a huge program. We had a very clear process by which we reviewed every single science glossary we could find in the world for hazards and every single UN glossary, amongst many other things. But what we ended up with was 302, bizarrely, hazards. They included the hydromet hazards, the extraterrestrial and space weather ones, the geohazards that, funnily enough, have no UN home most of the time, so they're much harder to implement. Maybe that had something to do with the Syria Turkey earthquakes earlier this year. The environmental, the chemical, but we got the biological hazards in there. At last they were there, and many of them, everything from One Health all the way through to individual cases, but many of them with umbrellas and chapeaux. So many hazards can fit in. And then the technological hazards, which of course include building collapse to cybersecurity to waste, transport accidents and radiation. But we were also allowed to include for completeness, although not part of the Sendai framework, the societal hazards of conflict to economic shock. So what do these look like? They are simple one-pagers on the whole, with the highest level definition we can find at the UN and other places, at the information that is most accessible, most open, and most transparent, with all sorts of data in there to try and make it more accessible, useful, usable, and used by many. So what is the recommendations? These need to be used, these hazards, to actively engage policymakers and scientists in evidence-based national risk assessment processes. All those things that we've talked about in the past. It's for disaster risk reduction, risk-informed sustainable development, and other actions aimed at managing risks of emergencies and disasters. They're increasingly being used, but now we're heading towards addressing that complexity, Mick, that has been so important in the WADEM conference. Addressing those cascading and complex hazards and risks so we begin to understand the very busy lives we had with COVID and many other of the events occurring around the world. And what we do know is we need regular review and update, and maybe it's time for a phase 2. But why does this matter? Is this just for the Sendai framework? No. We suddenly found that UNDRR and the International Science Council stated that these technical report and hazard information profiles support the Sendai framework, the Sustainable Development Goals, and the Paris Agreement. What for? By providing a common set of hazard definitions for monitoring and reviewing implementation. So they're absolutely at the heart of the work that we do, and they're needed in many, many different levels, from disaster-related statistics that Kanza in our team in the UKHSA has been leading on, but also to many other pieces of work, including early warning systems and early action. Something that has been called for by Antonio Guterres as the UN Secretary General, that we have to have in place by 2027. So there's a huge work program that we're now doing with the World Meteorological Office. But is that enough? No. Because we have climate change. Is that an opportunity or a challenge? So I wanted to share with you one of the papers that we published at COP27. It's a wonderful program of work called the 10 New Insights. I don't know how many of you have seen it, but I had the great privilege of being one of the 64 authors to help deliver this, focusing on Insight 3, which I'll share with you in a moment, which is the health one. But I thought there were a couple of others you need to know. So the first one is questioning a myth. Can we always adapt to climate change? So one of the statements they made is our potential to adapt to climate change limits people and ecosystems across the world, and it's staring them in the face now. We know that we will have soft limits, that dotted line inside that stripy bit of how far we can adapt, and hard limits. And there's a huge range of things we cannot cope with. Nor, sadly, can the rest of the planet. So we better get on and do something. I found this a very telling slide from my colleagues who were looking at the amount of adaptation we could do. We also know that there are vulnerability hotspots, and they cluster in regions of risk. They reported that by 2050 there'll be 1.6 billion people living in these vulnerability hotspots. And just to show you a global map of the work we do, where they are, these are glaciers melting, issues about monsoons, droughts, and we show you how much evidence is around them and what we need to think about. And of course, sea level rise. And there are so many small island development states. There's so much of the east coast of the USA, for instance. Oh, and the UK, we've got lots of islands.
No loss there.
That sea level rise is there. But let's think about the new threats on the horizon from climate health interactions. We know that the health of humans, animals, and the entire ecosystems are increasingly widespread and new risks are emerging. So how could we show this so you could understand it? So this is my precious Health Insight 3 that I am one of the 4 co-authors for. You will see that climate change sits at the top. You will see that we are really concerned about the impact of these events. You will see that we are worried about the increasing number of events we're going to face, but that we must have surveillance systems for them. You will see that the impact we will have will include the problems of microbial resistance, the increased use of pesticides, but also the impact on One Health. You will see that there is mental, physical, and other health impacts which don't just affect humans, it infects our entire ecosystems. So we need our wonderful epidemiologists and surveillance mechanisms to understand this so we can plan for it. So what does that mean for you and I individually, these big things that we need to think about? Well, so many of you work in frontline medical situations, in emergency departments, as paramedics, as pharmacists, as vets, as whatever. Well, there's some wonderful resources out there that are growing. These resources are really key to how we take things forward and how we're going to make a difference in the future so much more clearly. And I just show you a wonderful series of these so you can have a look at them, and I'll be talking more about this later in the day at another session when I bring together the work that we've been doing with the World Health Organization and the World Meteorological Organization on some of the extreme weather and other events. But how do we manage this ourselves? So UK HSA, we sat down and looked and thought about how do we get an image that tries to show what we see for health impacts. And I go back to our wonderful work that George Luber did at CDC, pulling together all the issues about extreme temperatures with extreme heat, severe weather, to the air pollution, to the fact that we're going to get different vectors that are coming in. Thank goodness we have a medical entomology team, to the increasing allergens, to the water, food, and of course in the environmental degradation. We took that and we thought about it really hard, along with many other issues, and we realized that the impacts of climate and environmental change are going to increase illness and deaths, but frighteningly yet again increase health inequalities. We have to work on this to manage it better. So, what have we done since? We have set up a Centre for Climate and Health Security, of which I'm only a development lead. We have a wonderful new head called Professor Leah Barang-Ford, who is going to take all our partners in this forward. So our centre was launched in October last year, and what we're trying to do is to work really hard to bring all our UK Health Security Agency links locally, nationally and internationally, that we can increase awareness of the impact of climate change on public health and build the evidence base and then mobilise it to inform policy and practice development. What have we actually done so far? Well, the centre has been set up with a focus on partnerships and collaboration with academia, with local authorities, but with many other senior public health organisations. And I very much hope WADEM will take forward its wish to get much more involved in thinking about climate and health security. At the end of April, and launched yesterday, we published the Adverse Weather and Health Plan, which pulls together our heat wave plan, our cold weather plan, and many other plans into one place, so people will find it easier to access and understand what to do. We will publish the 4th edition of the Health Effects of Climate Change. I've got a chapter to review tomorrow very fast on flooding, to think more about it. But what we know is with our increasingly adverse weather, and the potential for impacts on our food security through the risks of mosquito-borne disease becoming endemic in the UK, the risks we face now are very real for all of us, and we all need to do this. So our Centre for Climate and Health Security is a cloud. It's not fixed. It's there to help all. We will take the all hazards work I've shared with you, that approach to try and inform, because climate change is not a hazard, it's a driver of these hazards. Our collaboration for collective impact, our leadership and partnership skills that we have. We will be solutions orientated. We will be policy relevant science to try and make sure that we include the relevant science to try and make sure the policies reflect. We feel very strongly we can learn from global to local. But what we do locally might help global. So that partnership is absolutely key. And we will focus on equity. So it's fair for all, and be a knowledge broker. And that way, protecting our health in a changing climate might help to reduce the fact that the climate crisis is a health crisis. And this time, we don't have a vaccination. So I've shared with you some of the opportunities and challenges that I see for public health preparedness and response in the Sendai framework and its other UN and related organisations, landmark agreements and frameworks, by showing you a pathway from COVID to our thinking for our wonderful health emergency and disaster risk management framework, which I hope you will all use because it certainly contains a lot about health capacity and how we need to look at that, and that's something you've all talked to me about, to our tremendously exciting research guidance. Riamar, I so delight in it. To have the book here, to get you all to sign it, has been a joy. I'm so pleased we're delivering on something. To the incredible work we've done on building the global hazards with our many, many wonderful partners, to the hazard information profiles. And Stacey, I'm not sure you're in the room, but you suddenly told me, explosive remnants of war, that's what I'm working on, and I need you to add this. So that's the exciting thing of meeting people again. You pick up things that we may not have seen, and you can share it with us. So there you have that ring of hazards that interact and cross-cut, to the need for early warning systems for all. Otherwise, our emergency departments and other healthcare mechanisms will be under even greater pressure. And then looking to the fact that the climate crisis is a health crisis, and how can we all work together? Thank you.
Thanks, Virginia. If I could just get you to join me up here, I am absolutely sure we're going to have hundreds of questions. Probably better to put it up that way so people can actually see it. It's one of those bedtime reading books, and if you can't get through it all, you could at least use it as a pillow. It's quite big.
Thanks.
Very interested in the last section there, your ring of hazards. And to follow on from the theme last night, it's a little bit of a Johnny Cash ring of fire.
Well,
where do we go? Where do you start? And if you were a young first-time attendee at WADEM, listening to your call for people to get engaged at EDRM, how do they do that?
Well, the most important thing is we've tried to include health in each of our hazards. It's not there for all, but I think what we've done is to show that these impacts will affect the health system, the health of people, and how we should manage them. The risk management is much harder to do because each country will have its own systems, so we've had to describe the drivers and the outcomes. But trying to pull this together is really important. So one of the things we've concentrated on is including the UN treaties and the conventions so that you can influence, by using those hazard information profiles, your colleagues that may be in the policy making in the fields that are going to have an opportunity to really engage, while you on the ground can think about how you deal with these hazards. I mean, one of the things that came through to me listening to so many here has been that we don't have opiates as a hazard, but we do have counterfeit medicines. So that is included. We got that through from WHO. But listening to all the concerns, particularly from our US colleagues, should we have opiates? I don't know. We'll have to take it back to a steering group to see whether or not they feel that would be appropriate or not. But we did get individual events that I think are so important. So snake envenomation is there. But the impact of snake bites globally is so shocking, and WHO were great advocates for making sure it was there.
You do know we don't have any snakes here.
Well, you're okay in Ireland, unless you go to the zoo.
Well, okay, and they don't tend to get out. We had a St. Patrick who just banished all the snakes.
Oh, well, that was very thoughtful of him.
It was really far-sighted. That was
Well,
nearly 2 centuries ago as well.
No, I did talk to Michel de Backer about that and said there were no snakes in Ireland when we were on the bus. But I think to me what's so important is that it's not just snakes. It's all these things that we really need to be so much more alert for and know that we've found a way of documenting them. Because one of the things that's come through very strongly to me is the incredible way that we've managed to build data for COVID. It may not be perfect, but we have the international health regulations, we have to report. And for us in UK Health Security Agency, having been the national focal point for the UK reporting, there were a lot of databases to go through, but we did it at 4 o'clock every day, just about. And it was amazing what was done. But do we do the same thing for heat waves? Do we do the same thing for a chemical accident? Do we do the same thing for terrorism? Think of the events that happened in Brussels. Eve, I don't know whether you're here, but you certainly added a lot of the summaries to me about what happened in the Brussels bombings. You know, it's really hard work pulling all that data together. And when we had our London bombings, we certainly could count the number of people who went to the hospitals, but we were not so good at counting those people who went to other healthcare facilities for treatment. We're not good at providing data, and you cannot manage what you cannot measure.
Interesting phrase. I'm really interested in the opiates part, because in the United States, when road traffic collisions became a significant cause of mortality in the 50s and 60s, it set up the National Highway Transportation Safety Administration, NHTSA, which ultimately set up the pre-hospital system in the United States, because there were 30,000 deaths a year on the road. There's now 36,000 deaths a year from opiates, and there is no national opiate agency in the United States.
Well, I think, I mean, I'm also I'm very relieved to see that in many countries there are helmets on motorcycles for people who ride motorcycles. But the number of accidents you see in developing countries, even in Chennai, in India, I mean, I think when I went round that hospital, there were over 180 people who were on ventilators because they'd come off their motorbikes. You know, how do you count those figures and turn it into an action that's going to make a difference and save life? I think our health domain is responsible for much better sharing of data, not just in the times of a public health emergency of international concern, such as COVID. We need to do it for many of the events so we can actually influence what happens outside the hospital to try and reduce the impact of what happens inside. So let's be more proactive, all of us. Let's use these hazard information profiles to do this. And actually the definitions on road accidents comes from the UN ECE. They have the most phenomenally good definitions on road accidents. I was really thrilled with them. And I think that's a very good hazard information profile, but there are things that I'd like to add now that I've thought about it further.
Okay, so if you were looking at this, or the communications people in the audience, if there's any of them here looking at this, there was a quote just at the end of your slides, which was fantastic, I think. There's no vaccination for a climate crisis. And it's a very short, powerful message.
Well, I think the climate crisis is a health crisis. Is actually the most important message in many ways, because I think we all assume it's all about mitigation and adaptation. But the fact that there are limits to how much we can adapt, both in the soft and in the hard ways, I think that means we better get on and do something, not just assume that we don't need to. We have to, each one of us. And I'm drinking coffee. Coffee is growing further up and up mountains. Maybe coffee will not be available in the future.
Don't say that.
So delight in it today. You may not have it tomorrow. I mean it. And chocolate.
I think I'm getting chest pain. Is anybody, I don't want to hog the whole discussion here. Yes, sir.
Thank you very much. Virginia is an amazing person, and we are very proud in WHO to collaborate with her, with all the work she's doing. My point is, as health emergency specialist, how can we link this risk mapping or risk monitoring with proper health preparedness interventions? Because I think we are all in this conference to see how this can be done. We were all surprised by COVID, maybe because we did not manage well these potential risks that are linked to different pathogens. So what you are presenting shows that we still have a lot to do to ensure that at least we link all this risk management with proper monitoring system, but also preparedness on how we will manage the impact. Thank you.
So, Michelle, thank you for your lovely message. To us, it is the greatest privilege in the world to work with WHO and your extraordinary leadership. You have been amazing. Can we do a round for WHO? So, Michelle, in your role working with Mike Ryan, and the work you've done on pulling together our understanding for COVID has been extraordinary. But the whole purpose of these hazards is to make us look at hazards that we hadn't thought of properly, and trying to make sure that we can deliver it better. So one of the hazards that at the moment is one of my headaches is healthcare waste. How on earth are we going to manage all of that? The consequences of PPE. How are we going to manage the cybersecurity issues? Look at your IT issues in Ireland, shutting all the hospitals. So you had to do paper and pen again. And did you have to get medical students with forked sticks to run with notes between patients? I mean, the fact that we are so reliant on these things, we need to think through and protect ourselves better. We were hit really badly by WannaCry, a malware virus that affected our NHS systems. But when the National Audit Office did a review, we got some money in there to help try and deal with it. But this is the reason why these hazards are there, Michelle. It's to make us think, is this my problem? Not all of them will be. Not, you know, even in Switzerland, you don't have the coast around you yet. Yet. But you do have a lot of glaciers that are going. So are there things in there you've never thought of that we need to prepare for? And that's why this all hazards approach was such a revolution to me. And if we do phase 2, we need WHO's thinking behind it to make sure we don't fail you. But also we need all of you who identify something that we haven't included. Could we actually include something that you need? The work that we've had from Japan, the incredible work on tsunamis and earthquakes, I mean, what you've had to go through in Japan, Shinichi, and your many colleagues in Sendai and Sai, that are so memorable to us that we hope we've included those in the hazard information profiles. But are there other things that we could learn from Japan you could teach us? Because we know that from our weekly Global Hazards Bulletin, Indonesia and the Philippines, they come up practically every week. And you sit on the ring of fire. But there are many other things that we should do to work with you to see whether our hazards are inclusive enough and engaged enough.
Take the question here.
Prof. Murray, it's a privilege to listen to you. My name's Dr. Aslam. I'm the founder of Disaster Medicine and Dentistry, been working on the front lines. I wanted to bring your attention to something you're reviewing. You said tomorrow, floods. We've been working in Pakistan since September. And you talked about many issues where we can support and, of course, mitigate the consequences of such disasters globally. But my question really is relating to how we can support the countries, the people of the country. So infrastructure has been a real issue. And a country like Pakistan, as some of us may know, crises upon crises upon crises. One of the issues we faced was, so in Khyber Pakhtunkhwa, the northwest of Pakistan, so I'm ethnically Pashtun, I speak the languages, and I was able to understand the locals' appreciation or lack of understanding of sort of the causes potentially contributing towards these devastating floods. And there was a lack of understanding, especially in the rural areas. They consider it an act of God. There's very, very limited understanding of climate issues, of the lack of or the frail infrastructure. So I just wanted to invite your thoughts on this, please.
So Pakistan is a very precious country to us. We have from UKHSA our IHR project, which Tina can share more with you if it would be helpful. We've really worked very closely with Pakistan health systems, and we would love to do more with you. But trying to share what climate means to people, I think is something we have to go out and advocate for. And maybe some of the slides I've shared with you today and the incredible reports from the Intergovernmental Panel on Climate Change, the wonderful work of the WHO climate team and the WMO climate team, I'll be presenting that later, I think is something that we all need to be aware of and have in our back pocket to pull out and to be able to do this. And if there's anything we can do, please, let's see what we can do to help. It would be an honor.
Okay, we'll take a question.
Are we running
here,
out of time?
We're running out of time, so we need to be really brief and pointed to the question.
Okay, I'll do my best. It's Lisa Schwartz from McMaster University. First of all, thank you so much for your tireless work, Professor Murray. You've been a leader in this field for so long and an inspiration. So I wanted to know a little bit about how we engage the community. Since the first day in the various talks, people have been talking about the strengths of relying on community. We've just heard how difficult that can be, and I'm working with building a project for Pakistan just now on learning from community how they have adapted, given the myth. Spent the last 3 years working with WHO on leading in community engagement for the vaccine trials as well. I'm curious to know, because the bubble was always there on the slides, how are you talking about and how are you thinking about learning from communities first, how we pay attention to what the needs are, and also the creativity and the originality of how adaptations have taken place?
Just a little question, but a fantastic one, thank you, as always. To us, communities are vital. So we're increasingly looking at working with the young. I was at a meeting only in the end of March with a whole group of school children, and I thought that was absolutely critical. Hearing their voices, hearing their needs, listening to them. And that to me was a great privilege. But also working with the local teams trying to respond to that. And that's why we feel the local networks for us are so critical, and trying to understand how we can do this. And with our academic partners who are also doing so much of this work as well. But yes, let's do more. It will be amazing. Perhaps we can talk later.
Which is a good suggestion, maybe for the final speaker. We're 4 minutes over now, so if you can get this in 15 seconds, great. If not, I would maybe suggest respectfully you take Professor Murray individually for your question and have personal attention.
Very quick question. It's in relation to up to 75% of new or emerging infectious diseases come from animals. We know the statistic, up to 75%, it's massive. Right now, there's minimal, at most minimal, surveillance of wildlife, of companion animals, and I want to know, in this incredible book that has just been published, is there guidance in that regard?
This is about research methods, but in our hazards there's a lot on One Health. So please come and share and talk, and maybe Kat, who's in the audience, who I see there. Kat, thank you. We'll talk with her because she's doing a lot of the One Health work with us, but also our wonderful medical entomologists we have in the UKHSA, who are actually collecting the insects, analysing them, doing the work. The focus has been huge. It would be wonderful to share with you what we're up to. And perhaps you can tell us what you're doing. It'd be great.
There's a teenager's boy's dream, collecting insects.
They're pretty good at it, and they terrify us every so often with telling us what the results are. Around airports, very interesting.
Thank you so much. Wonderful talk. Thanks.